When their patients are diagnosed with sleep apnea, there are a number of treatments available, but the primary treatment for obstructive apnea usually is CPAP. Dental devices are available, but they're only appropriate for patients with mild sleep apnea. Anything more severe than mild, it's not even appropriate to consider. Oftentimes the treatment can be a success with the dental devices, but they should be studied or screened along the way when they're used to see if they're actually effective or not. Excuse me. When we also look at sleep apnea, the primary treatment is CPAP, continuous positive airway pressure. And all that the CPAP does, as shown by this slide, is that it provides an external pressure on the end of expiration. So in other words, when the patient expires down to their normal end expiratory rate, there's a slight pressure that is kept in there that actually works as an internal air splint in the neck, and it helps keep the airway open, so that by the time the patient then initiates a breath and the negative pressure is created, then it won't suck the airway closed. It's a very simple, actually, treatment. Takes a little time to get used to, but is very effective when used. The biggest complication we see is the complication of patients just not bothering to put it on. So the patients need some degree of follow-up when they have this therapy, and they should be followed and encouraged to use it. The literature tells us that it's important for you to give them a call and talk with them and work with them right in the very beginning, that their first few days of use have a big impact on the future, and the first 2 weeks will probably determine what their total long-term compliance with the device is. Overall, many people have reported that the compliance is around 50%, and so it bears reminding that that's very similar to maintenance medications like bronchodilators, hypertensive treatments, any of the chronic disorder treatments. And this can be improved with CPAP simply by having good education for the patient and good follow-up for them. When you have a good sleep center, they'll provide a lot of the instruction and education for them and help with probably recommending and fitting a mask for them, an interface for them to wear with their CPAP machine. There are a couple of different types of positive airway pressure. CPAP is the most common. It has the one pressure that I mentioned and keeps the airway open on end expiration. BiPAP, on the other hand, has that one expiratory pressure, but it also has an inspiratory pressure. So for patients who underbreathe, it can provide a boost to their inspiration or provide pressure support, and then they don't tend to have the hypopneas. So what are the goals of treating obstructive sleep apnea? It's to actually stop those periods of time where they wake up during the night and bring their AHI, the apnea-hypopnea index, down so that the quality of their sleep improves, and so that they don't have that stress response repeatedly throughout the night. The quality of their sleep improves. They get the benefits of being well slept. The stress level drops down. We then decrease their risk for all the cardiopulmonary events. And that's only if they wear it, so they generally need the support to use the therapy during every sleep period. And in fact, if people work a couple of jobs and sleep a short period and then nap later on, they should use the CPAP with naps. So long-term compliance and long-term therapy then involves continual education with the patient, assessing their therapy, do they use it, and many of the devices actually provide the ability to be downloaded and look at how the patient used it, what their airflow looked like, and that provides us then in follow-up with the opportunity to say, is the therapy being effective? And additionally, to answer the question, should they possibly be changed to another mode of therapy if this isn't effective, that they had an underlying other sleep disordered breathing pattern that maybe needs to be treated with a typical or different type of device. What we're looking for is acceptance, tolerance, and response. So we want them to accept the therapy and use it. We want to make sure that they tolerate it well, and we support them for that, up to and including changing their masks and interfaces. They've never experienced this therapy before, so when we put them on, they may choose a mask that's simply nasal, or that is nasal pillows that only goes in the nares, or that covers their nose and their mouth. But since they've never experienced it before, what feels comfortable day one, after they use it, they may find device, another patient interface might be more comfortable for them. So we follow them, we change those masks as needed, and we provide maintenance on their machine so that they can have long-term effective therapy. We should then decrease all the risks for the comorbidities, and that improves the cost of health care overall. So it's important that you recognize those patients again and look for the symptoms that we see, and if they're there, then you refer them to a sleep center. And certainly you can contact the Dow University and see how they're coming with theirs and how you can get access to that. So I thank you for your attention and hope that this has been helpful for you in looking for patients in your practice whose maybe current treatment for things like diabetes or asthma or atrial fibrillation isn't as effective as you would like it to be, and consider they might have untreated sleep apnea. And then if you find these patients, and then you can have them diagnosed, treated, set up on CPAP therapy, and know that they'll come back for you for follow-up, and I hope I've made that a little more comfortable for you to provide. Thank you for your attention.